This was a talk Asiko asked me to give, and it's a slightly different topic from what you normally hear in scientific meetings. And I'm just going to concentrate on how the design of certain surgical instruments can improve your cataract surgery outcomes. Okay, so as surgeons, where do we get our kicks from? Well, we get it when our patients are happy with successful surgery, we publish papers, you have a good private practice, you're all happy, like we have new equipment, new lenses, or when we teach new generations. But what about designing surgical instruments? Have you ever thought about it? As surgeons, we think we are very powerful, right? But without the tools of our trade, without instruments, we are nowhere. We would just be like this monkey examining his mother, right? With no equipment, no lenses, no slit lamp, no phaco machine, where are we? So how do we start designing surgical instruments? Or should I say, what should your objectives be? Are you going to try and make money, sell thousands of instruments and become a millionaire? Not so easy, huh? Maybe you'll become famous if your instrument is really popular. Or maybe you can fulfill a medical need or avoid, and usually it starts with your own need. You're doing surgery, you find, I wish I had a better instrument to do this. And that's where many ideas start from. You might say, oh, everything's been invented already. But if we felt that, I think all the new developments wouldn't be here today. There's always something new to be invented. For example, Harold Ridley invented the IOL in 1950. Okay? And of course, since then, we have many, many advancements. One of which, of course, is the toric IOL, which is only 10 years old. Okay? So 10 years ago, we had the toric IOL. And as you all know, we've had many talks on the use or how do we align up a toric IOL. And many of these techniques are used. The slit lamp is very good, photographs, Callisto, and other markers. So the first instrument I'm going to talk to you about, which I designed, was really because I was not very happy with the big, very bulky, the designs are heavy, and they're actually quite expensive, these bulky markers. But what's worse, you can't really see the eye under it. Okay? So, and then I tended to use a simple Mendes marker. Now, I think many of you will be familiar. It's cheap, it's very easy to use, but if you look at it, there's so much metal there. Why do you need so much metal to put into the eye? You know, our eyes in Asia are sometimes very small, simpit, scaly, and not easy to fit. So I decided that this must be better. So many of these were designed for large Caucasian eyes. So instead of having such a big toric gauge, I've slimmed it down tremendously, and you can see there are maybe 1/4, 1/5 the size of a Mendes marker, and put it to the test. So you can see the difference immediately. The same eye with the standard Mendes and the new slimline toric marking gauge. And here we can see one of these eyes. Oops, sorry, let me go back up. So this is a real life eye. You can see a narrow palpable fissure. The Mendes gauge is actually on the eyelid over there on the right. It does not sit onto the sclera of the eye. And so here we see the difference with the slimline toric marker that Asiko have made for me. And you can see this fits into this very tight, narrow eye. And you can see the two reference marks that I had made earlier, just about there and there. But you know, sometimes when the eye is small, the ring will occlude or block the view of those ink marks. So that's why I put in some cutouts. See, when you have the cutouts, you can usually find a position to see the ink marks more clearly so that you can then do the reference marks. But some of my colleagues are very difficult people. They don't like to mark at 0 and 180 like this. They want to mark at 90 and 270. So that's why then I had to modify the design again, and we put 2 more cutouts at 90 and 270. So wherever you like to do your reference marks, you can actually still get a good and effective marking. And once you've done that, then it's very, very easy to do your axis marking based on those reference marks. And today, I think this is still one of the designs that I think people quite like. Look, obviously, this works in our narrow Asian eyes, but it works just as well if you've got a large Caucasian or an Indian eye. Very easy instrument to use. So that's the first instrument I talked to you about, the slimline, suitable for small Asian eyes. It's simple and really fairly affordable. But what about these new technologies? I mean, you all know, you've heard about Callisto, you've heard about Varion, you've heard today about Holos and Verify. All these expensive technologies. I mean, I don't have this technology in every hospital I work in, and so many times I still go back to simple manual marking of the eye, and that's where the simple toric gauge, I think, is very, very useful. Now, the second topic I'd like to talk about is how do you fix your toric IOL in its final location, okay, and what some problems you might have. Now, here you will see a patient who is challenging because the pupil is small. I'm reaching under to get it, but you see I've missed the haptic, so I get the right position, and then I'm dialing it around. But look very carefully on what's happened here. You see that line? You see that line there? When I was rotating that lens blindly, I ruptured that posterior capsule. It's a rare event, and I thought that would be the only time it would happen to me, but I've done it 2 or 3 times. And after that, I decided, what's wrong? Why am I rupturing this capsule? Well, what I did was, then I looked critically, but what I did was I felt the Sinski hook, which was very, very sharp. You think it's blunt, but it's not. It's actually sharp. And so all I did was I put a little round ball on the end of it, and that makes it look a bit like a dialer or a mushroom, but it's much safer and very much easier to rotate a toric IOL around. So it's also fair enough to say that new surgical procedures bring new opportunities. You know, the cataract surgery has evolved from intra-cap to extra-cap to phaco, and now there's a femtosecond laser cataract surgery. So just as with new lamellar corneal surgery or newer glaucoma surgeries, we now have flex. And flex also lends itself an opportunity to design new instruments. So what are some of the issues? Well, incisional issues are always a problem with the femto. People have done all these fancy lasers and they can't open the instrument, or they can't open the incision up. So this is the very first flex case I did many, many years ago. Well, about 3-4 years ago now, and I used a Sinski hook to open that side port incision. Now you will see that I'm struggling to open this. And I wondered, we spent $1 million getting this laser and we can't do an incision properly. So clearly that was the wrong instrument, and that's why I said there's a void, there's a need that I perceived. So what I did then was, okay, instead of accepting that, then we move on and try and get a new instrument that hopefully will work. Okay. So here you will see an instrument that I designed. And this instrument shows that the main incision in a femtosecond laser procedure is actually very steep. So I have to raise the instrument up, and you see that my fingers now start intruding into the surgical field because of the steeper angle I have to go in. And so I actually redesigned things a little bit more. So the point to note is that the side port of a femto incision is 10 degrees above the horizontal. The main port, so this is a side port incision that I've optimized the angle for. And then if you look at the main port, you can see it's much steeper. So when I've done that, you will see that with the new femtosecond laser spatula, I can open that side port very, very easily. And with the main port, my fingers no longer get in the way of the surgical field because it's been optimized and designed to open these 2 incisions specifically. And nowadays, this is also doing very well. And these are my original drawings, which I gave to ASICO and said, can you make them at these correct angles, which is optimized? And this is something that ASICO is very open to. If you have an idea or a surgical need in any aspect of surgery that you find, hey, you know, can I do better? Come up with a drawing. All you need to make these, you see these are my own pencil drawings. And you just give it to them and they'll have a look at it, and if you can convince them that it will make surgery easier, they will make you a prototype and you try it and see. So the advantages of the femto spatula, I've tapered, I've beveled, I've made them the appropriate size, but more importantly, I've angulated the spatula and the shaft to the correct angles. That just makes this a very much easier procedure. What about pre-chopping? Now, with femto surgery, some of us think that after the femto step, removing the nucleus is very easy. It isn't that easy because the femto laser only divides it maybe 3/4 depth. The base is still attached. And if you're trying to crack this, sometimes it's hard to grip, it's hard to chop because you've already lasered it. So you need something to help you, okay? And I think that pre-chopping helps this very much. And our friend Taka Akahoshi, who's the greatest pre-chopper in the world, recommended that I try one of his instruments for this particular job. So here you see a ring pre-chopper with a hole like a polo mint inside. I put into this femto lasered nucleus. I insert it into the femto laser slot and I open it up. And you can see that completes that 80% crack I told you earlier and really has brought it all the way down to the back. Okay, so that really worked very well. Then you just need to rotate it 90 degrees with a little bit of hydrodissection and you complete the cracking of the whole nucleus into 4 separate quadrants. And the rest then is very, very easy. You can use whatever cheap phaco machine you want or that you have to really extricate each of these quadrants out most effectively. Okay, and you can see here, then you can go in and grab that. That's easy. Let's not dwell on that. But then one day, my nurse gave me my instrument for the next case, and you see in the middle of that hole, there was a plug of nucleus left from the last case. It meant they weren't doing their job properly. They didn't clean my instrument properly, or the autoclave didn't work properly. But I said, oh my God, why? Why do we need a hole in this instrument at all? And if you think about it, if you fill in that hole, you're actually going to be more effective cracking the nucleus. And then you won't get that problem of nucleus stuck in the hole. So I then redesigned Taka's original instrument, filled in that hole, closed it up, and I call it the paddle pre-chopper. I also made it as slim as I could, and I made the crossover, where the crossover joint is, as slim as it could be, because we're going through much smaller incisions than when this instrument was first designed for standard phacoemulsification. So, and then as you can see, this instrument goes into a femtolasered groove, and you open it up, that cracks it beautifully, and there's no risk whatsoever of nucleus getting incarcerated and stuck in that hole. So today we no longer make that donut ring pre-chopper, and ASICO now makes this paddle pre-chopper, which is a femto pre-chopper. Now you might ask, can we use a standard Akahoshi combo pre-chopper for this? Yes, you can, but if you've seen those, they look like a great big knife with a very sharp point, and you know, people get a bit nervous about that. And the fact is, once you laser that groove, you don't need that sharp point anymore. So this is much more useful. It's also bidirectional. In other words, you don't have to put one end of it in and instead of the right way up. So it's safe, it's bidirectional. But I would say it's ideal for the softer nuclei up to 2+. In general, pre-chopping for the much denser nuclei is more challenging unless you put a nucleus sustainer on. As I said, be careful with denser nuclei. Okay, so these are just some of the instruments I talked about, and you can see what I talked about earlier. So that's the slimline ring pre-chopper. It's like a Sinskey hook with a round ball at the end, just for safer dialing of the IOL. And this is the double-ended spatula, and this is the paddle pre-chopper, which are the 4 products that are already in use. But of late, I've been working on something else with ASICO, and that's paying a bit of attention to the side port in phaco. Now, how big is your side port? Do you know how big your side port is? You're not sure, right? I mean, we all make a side port. We poke a knife in. Is it 1? Is it 0.5? Is it 1.5? You're not sure. All I know is that if you're a bimanual IA person, your incisions are at least 1.2, if not 1.4. Okay. Now, why is there an issue with side ports? Well, if you think about standard chopper or splitter designs that you put through the side port, they are usually cylindrical in cross section and they have a taper. Why is this taper an issue? Because when the thin part of the instrument is in the wound, it can leak, right? And if you make it too tight, then you can't put the instrument into the eye. And when you're making it bigger, then it leaks and your chamber is not as stable as you might like it to be. So what I've done is I've designed some new flat profile splitters where the shaft that goes in is no longer round and tapered, but flattened, which allows easier entry into the eye. And you can make your incisions down to 0.5 and with less side port leakage and more stable anterior chambers. So here you will see a side port that I'm making. You can see it's a pretty small incision. Now here is the round, normal splitter or chopper that every one of us has been using. You see how fat it is, but you also see how it slims down to the tip. Now, I've made a fairly small incision. This is probably 0.5 or 0.6 millimeters. Now, you'll see when I insert the instrument in, and I'm trying to reach across, it's stuck here. It won't go anymore. It's watertight, but I can't chop. I can't rotate. It's a problem. So we need to then make it wider to allow it to go in. But when you're making it wider, it will leak when this part is in. And that's something I think we haven't paid attention to enough over the years. Okay, so here you can see I'm struggling with that. So I said, okay, let me have my new prototype. So this is really the only prototype of a flat-topped splitter that I have. And I just got this a couple of months ago from Esico. You can see on top it's flat. And it's flat, there's much less, it's not like that, it's like that now. Okay, I would still like to see less taper, but engineering-wise, I think they have a problem in not tapering it. And so that's going in. Now you can see this is able to reach across to the other side to do a chop. And I find that this works very well. Now, how do we measure side ports? Yeah, I asked you the question, how big is your side port? I bet all of you don't know how big your side ports are. Maybe you don't think it's important. I think it is, okay? So here's a new instrument that Esico came up with. Ravi, is this an old design or a new design?
Was something similar, but your idea was to make it more like rounded also.
Right, so you see this. Now I put this gauge into the side port. This is 1.1 of 1 millimeter is about here. You see that 1, and then 0.9, 0.8, 0.7, 0.6. And you can see this is 1, 0.9, 0.8, 0.7, 0.6 is probably 0.5 in there. Now this is the only way you're going to know how effective or ineffective your side ports are and how big your side ports should be. And you can see that through that same 0.5 or 0.6 side port incision, I can now put this flat-topped splitter, and I like to use this instrument for almost all. You can see the flat top there very, very clearly. So it goes in easily, and at 0.5, I guarantee you there's minimal leakage, whichever part of the shaft of my instrument is in the eye. All right? And then you can see you can just carry on with that chopping very, very effectively and get on with the rest of the surgery. Yeah? So I'm just going to sum up this very brief talk on instrument design by saying, you know, of course you can sometimes have a brilliant idea and design a totally new instrument that nobody else has ever thought about. But that's not so easy. Because cataract surgery has been around for 30 years, you know. It's much easier if you modify a previous design. Somebody else has an instrument and you find, hey, it's not as good as I'd like it to be. You have an idea, change it. Or you have a new use for some old designs. So just to end with, where do I get my kicks from in instrument design? Why do I bother? Is it so that I can be as famous as the Sioni ring, the Malyugin ring, or the Kelman forceps? Well, not really. I get a kick when I see other surgeons use my designs. Okay, and I go to a lot of meetings, and I see usually in live surgery somebody use my toric gauge, or they use my pedal pre-chopper. I get a thrill from that because I think at least I've made a difference, and some other surgeons agree that I made their life easier, and clearly the patients will benefit. And I put to all of you that you all have a eureka moment in you, that you can all design something that will make all our lives easier. Thank you so much, and thank you all of you for coming and listening to me.